Yeah.
Wendy, can you hear us? We can't hear you.
Got on mute.
I think you're muted.
I just clicked it. She's going to unmute now.
I unmuted.
Yeah, that's Wendy, right?
Yeah, Wendy.
Yeah. Can you, while we're waiting for Dr. Jacob, can you talk without too much pain, Wendy?
Yeah.
You want to share with the other people who join as we go along? You want to share some of your symptoms, and let's see if some other members might be able to chime in and help.
Okay. My symptoms are I have pain across the forehead, pain around my eyes, pain at the temples, pain in the cheekbones, and it seems like the pain is coming from the ears across the cheekbones over the bridge of the nose, and then under the cheekbones, and then under the jaw. And
wow.
it hurts to chew. It hurts to talk for long periods of time. I'm having, like, I've been diagnosed with occipital neuralgia also. So I've had nerve blocks for my occipital. And what happened with me was, it was the ears, nose, and throat doctor, was the first doctor who said, I think you're having facial nerve pain. And then he sent me to neurology. Neurology, at first they said, yeah, we think you're having facial nerve pain. And now they've come back and said, no, you don't meet the criteria for facial nerve pain.
Yeah, and that sounds like what we've been through as far as not fitting the criteria.
And then I saw Dr. Malik today, the neurosurgeon at Henry Ford, and he said, because I'm not able to exactly pinpoint when the pain started, that it can't be trigeminal neuralgia. Because when you get a trigeminal neuralgia, it's so excruciating that you'll always know when it started. Does that make sense to you?
I had never heard that before.
Me either.
No.
What I don't understand is you do kind of know when it started, right?
Well, this episode of facial pain started March 11th.
Okay, so why would he say that he doesn't know when it started?
Because he's saying that usually there's a trigger and a diagnosis. So like it's dental work, and then within 48 to 72 hours, you know. Or if something happened and then you know right away. Well, my symptoms have been over a long period of time.
When did they first start?
Well, that's what I'm confused about is I went to the ears, nose, and throat doctor for chronic sinus infections.
Okay.
And my thought was, okay, he's going to do surgery. He's going to correct whatever is wrong in there. And I'm going to stop having sinus infections. And when I went to see him, he said, I don't believe you're having sinus infections at all. I believe you have facial nerve pain. And so he said, I'm going to tell you what I want you to do. Next time you think you have a sinus infection, come back in and let me look to see if there's an infection present. So I did. I thought I was having all the pain again. I thought I was having a sinus infection. I saw him March 16th. He did an endoscopy. No sign of infection at all.
Were you ever on antibiotics? Okay. And that didn't cut it. Okay.
No, 100 times over. Because that's what happens is when you think you have a sinus, you either go to your primary care or you go to walk-in clinic, and then they push, oh, does this hurt? Of course it hurts.
Yeah.
And then they give you an antibiotic
Right.
and they send you on your way.
Right.
Yeah.
I mentioned before you joined, Wendy, that I had 24 bouts of sinusitis, bronchitis in a 14-month period. But mine ended up that I did have, from an infected root canal, a hole in the sinus. So the infection was just dumping into the sinus. So that's
Oh.
logical. You might have thought that.
Oh,
Are you the one that had all the rear end collisions years ago? That's what I thought.
I had a rear end collision, head on collision, and I was sideswiped.
Wow.
So I thought that's probably, I don't know how you could not have nerve. Just let me interject here. I just received an email from Dr. Jacob. He's going to be 15 or 20 minutes. He's just finishing up clinic, as I mentioned when we started. So
Okay.
hang on, he'll be here.
Okay.
Tim, do you want to get to those line items? I don't mean to cut Wendy off. You do
No,
whatever
no.
you need to do.
Hers is more important right now.
Absolutely.
Yeah,
I'm just your sidekick.
Red. Oh, that's good, Pete. Thank you. Go ahead, Wendy.
So I'm trying to find out. So I have 2 doctors saying it's trigeminal neuralgia, the ears, nose, and throat, and the pain clinic. I have 1 doctor saying it's not, and that's neurology. And like I told you, neurology is not doing anything for me at all. They're not doing imaging. They're not helping me with my occipital neuralgia. They're not doing anything.
You mean neurology or neurosurgeon?
Neurology.
Okay. In addition to Dr. Malik. Okay.
Right, because neurology, when I said, I'm in a flare-up and I need, injections in my occipital nerves. The only people who have been taking care of that are my primary care doctor and the pain clinic. Neurology hasn't done anything. And everybody I tell that, I was like, oh, I went to see the functional medicine doctor, Dr. Swinor at Henry Ford yesterday. And I told her this. I said, I'm having this terrible flare up of all this pain in my face, my head, and my occipital neuralgia. I have 2 nerves blocks. And I told her, I don't understand why neurology is not doing anything. And she said, you mean to tell me neurology didn't do the nerve blocks? No. You mean to tell me neurology is not doing the trigger point injections? No. She couldn't believe it.
Where are you going for your neurology?
Henry Ford, Bloomfield Township.
Yeah. West
And
Bloomfield.
it's just a neurologist you're seeing?
Yeah, that was where the ears, nose, and throat doctor sent me to neurology.
Well, I don't think this guy's doing you justice.
That's what I think.
I
What
think-
about migraines, Wendy?
Yeah.
Haven't they talked migraines at all?
Well, this is what neurology is telling me now. Neurology is saying, I said, so when I posed the question to neurology on May 6th, I said, okay, if it's not trigeminal neuralgia, what is causing all this pain in my face? And she said, it's just a headache.
Just
Oh
Yeah,
my.
Yeah.
Now, when you would get these injections, would they help?
Well, I just got the injections in my bilateral lesser occipital nerves. And I just got those, and they did help the pulsating, throbbing pain. Because what was happening is I was having this pulsating, throbbing pain behind my ears. And then at the same time, I would get these electrical zaps.
Gosh, that sounds like classic TN then.
Well, and that's the thing. I'm like, it's like having a migraine headache and being electrocuted at the same time.
I told her
Wow.
Pete, about Lynn being away. These kind of things Lynn's good at because she's had some of those problems. Probably can hold off, like Pete said, and wait for Dr. Jacob. Save some of your energy, Wendy, because Dr. Jacob's going to be joining us You got my note I just sent you about 5 o'clock
At 5 o'clock.
today? You wrote to me about your Malik appointment. And
Yeah.
I wrote that. You got
Yeah.
that message?
Yeah, yeah,
Does your insurance cover Beaumont?
no.
Yeah.
So I want to tell you, the only way I can go outside of Henry Ford is if Henry Ford doesn't have a specialist in that area that does that. That's the only way they'll allow me outside of the system.
Yeah.
I know. It seems like once you get into Henry Ford, you're locked in.
Yeah.
Yeah. Well, you got their insurance. Well, this is a time for a free appointment when we got Jacob here. You don't have to ask your insurance company to talk to Dr. Jacob when he joins us. What
Right.
the plan is, we're going to let him present whatever remarks that he wants to, and then we'll get into a Q&A. And Wendy, you can not be first up, but we'll decide who goes first or whatever. I'm sure he'll stay with us as long as we want to. What's the Susan iPad number 2? That's not you, is it?
Oh,
I'll ask her.
I'm looking at the screen. We're trying to determine. Barb's on. I've got a suit. Did you pick that one up?
Here's Susan.
I'm the Susan's iPad, and I don't have my face coming up because I'm eating an ice cream cone and I'm sitting in the car.
No, that's
I'm in California.
What's your last name?
Mills, Mills.
Susan
You know
Mills.
me.
Yeah, I know you. But
And
yeah,
I grew up in Bloomfield Hills
right.
and in Michigan, and now I live in California. So I remember Beaumont Hospital and Henry Ford. So it's like old home week for me listening to you guys.
Yeah. Don't rub it in with better weather. Hi, doctor. Here's Dr. Jacob, I think, joined us.
He is.
Can you unmute, Doc?
I got him. I sent him a message.
Oh, okay.
Got it.
Hi, how are you? Welcome.
Thank you. Can you hear me okay?
Yeah, fine.
Great.
We've, I think I've done a fairly good job, hopefully, introducing you with the note that I sent out. I pulled that from multiple sources, and your people sent it to me. So I apologize for my hoarseness.
Sure.
It's not a neurosurgical issue. Or I would have come in to see you. So, but the plan is, I'm not sure if you had remarks. You were going to talk about the MVD, the Gamma knife, the percutaneous rhizotomies, as I mentioned, and then hopefully you'll have time for a Q&A.
Yes.
Okay, you're on. Go ahead. Pete Ruby's in the upper left. He's our host. Lynn is with her parents in Texas. She went down for Mother's Day and had to put her dad in the hospital last weekend, so she's not with us. She's normally, I think you might have met her when we had the meeting with before the pandemic at Beaumont Conference Room.
Mm-hmm.
Yeah, she's a nurse and an excellent contributor, obviously, to our group. And now she's pulled her husband in as our host. So go ahead, Doc.
Thank you. Well, thank you all for having me. I'm Dr. Jeff Jacob. I'm one of the neurosurgeons, primarily with Beaumont Health, but I also work in conjunction with Ascension, DMC, and McLaren Health. My primary area of expertise in my day-to-day work usually involves a condition called skull base surgery or skull base disorders. That includes surgery and treatment of trigeminal neuralgia, as well as tumors in and of the trigeminal nerve, nerves near the cerebellopontine angle or that location that includes the hearing nerve, facial nerve, swallowing nerves, and disorders of the brainstem. That, I'd say, involves the majority of my practice. Most of my surgeries I do at Beaumont Hospital in Royal Oak, as well as a little bit in Troy, Michigan, as well as Ascension at Providence Park in Novi. But because I'm the skull base surgeon for McLaren Health and parts of DMC, I get some of those referrals as well. I had the opportunity and pleasure to talk with the TNA group. It's been a few years now, I think. So thanks for having me back. It was definitely a great opportunity to meet Tim and Lynn and the great work they've done to have support for this very difficult condition. I know many of you probably by way of the internet have a good understanding of the condition as well as through consultations with your doctors, but I'll go through really quickly just in the interest of the presentation, just kind of briefly about it, and then spend more time hopefully answering questions for everyone. I don't know if you can see this. Let me share the screen. And
can you pull him up, Pete?
There we go. Can you see this okay?
Yeah.
Yeah.
Excellent.
Okay, great. So trigeminal neuralgia, as you all know, is facial pain. And really the big thing about this is the clinical history. And I go through this with all the patients I see in the office because the history, more than anything, is really what's most critical in nailing this diagnosis. There's lots of different things that can cause facial pain, including trauma, tumors of the trigeminal nerve, or the nerve that gives sensation to the face. Stroke, when it involves the deep nuclei of the brain, can cause trigeminal neuralgia or facial pain. Multiple sclerosis, all these things can cause different versions of facial pain. And it's important to really distinguish whether what the patient has is what we call type 1 or typical trigeminal neuralgia, or type 2 or atypical facial pain. For the purposes of this presentation, I will focus primarily on treatment of type 1 or typical trigeminal neuralgia, because most of the treatment that we do directed to the trigeminal nerve really revolve around the treatment of that condition in a more reliable way in terms of this presentation, but we can talk about the other natures of facial pain as well afterward. But typical trigeminal neuralgia is described as a lancinating or episodic, meaning not on all the time, but an on and off kind of pain that's very severe. And people talk about this electric shock-like or ice pick-like sensation into the eye or the side of the face that's triggered usually with cutaneous triggers like brushing the teeth, eating, chewing, talking, combing the hair, laying on that side, washing the face, shaving for men, things like that. When that constellation of symptoms happen, that's very consistent with this type 1 or typical trigeminal neuralgia. And that's purely a clinical diagnosis. No imaging or electrical study can really tell you that diagnosis. It all comes down to that history. It's not uncommon that patients I see have been seen by dental providers, oral surgeons, other oral facial pain specialists, searching for answers. Some of them even have had many of their teeth removed because they were thought to have a dental problem. And ultimately, they saw a provider that really honed in on this diagnosis of trigeminal neuralgia. Once that clinical diagnosis is made, just briefly to talk about the trigeminal nerve. So the trigeminal nerve starts at the brain stem as the root, then branches out into this trigeminal ganglion, which then exits the skull base into 3 divisions involving the upper part, the middle part, and lower half of the face. We can actually see the trigeminal nerve quite well using a very specific sequence on the MRI scan, which is a very thin cut sequence called the CIS or Fiesta sequence, where you can see here the trigeminal nerve exiting the brainstem. This arrow shows a blood vessel here. I'll talk about the implications of that and the usefulness of that very shortly. But you can see the trigeminal nerve and its course on an MRI scan pretty well. On other sequences, you can look at the other branches of the trigeminal nerve as well. The first step, once you nail the diagnosis based on the clinical history, is to get an MRI scan. And I only do that really to look for structural pathologies of the trigeminal nerve. So not to look for vascular compression, as some people think, because it turns out that's not so useful to look for that. But the things that I'm looking for are tumors of the trigeminal nerve, tumors from the hearing and balance nerve, like acoustic neuromas that in large size can push on the trigeminal nerve, or also stroke can cause facial pain, multiple sclerosis, and other cancers of the trigeminal nerve. That's the main thing that the MRI scan is utilized for, because we don't want to miss that while we're thinking about the typical trigeminal neuralgias and miss a cancer diagnosis of multiple sclerosis. Once the diagnosis is made, like I said, we do an imaging study to make sure the structural pathologies are not there. And by and large, the first line treatment is medical management. And the most common medication utilized for this is Tegretol or carbamazepine. Other medications include oxcarbazepine or trileptal, gabapentin, Lyrica, baclofen, and in some cases, some different new generation anti-seizure medications. In very acute crises, steroids can be used to cut the inflammation. And sometimes narcotic pain management is necessary in an acute scenario and in some atypical facial pain situations. The goal of these medical treatments is to basically, simply put, to reduce the excitability of the nerve. It turns out that the treatment response to one of these medications is quite good at honing in on this diagnosis, because patients who have a positive treatment response to trileptal, Tegretol, any one of these types of medications that reduce the excitability of the nerve, and who also have the clinical symptoms of trigeminal neuralgia, when they ultimately, if they fail or require treatment outside of medical management, a positive treatment response to this is a really suggestive of a really good treatment response to the non-medical treatments that we'll talk about next. So I use all of those as sort of a guide to think about what's the best treatment for each patient. If medications have a toxic effect, such as oftentimes patients feel like they're in a fog and can't work while they're on this medication, or just can't think clearly. Some patients can also get toxicity from this medicine, like a low sodium, which can sometimes be life-threatening. Some people can get a drug rash. But oftentimes I'd say that foggy state of mind is quite common in patients, and sometimes so disabling that they actually can't take it and be employable or functional with their family in any sort of meaningful way. If they fall into that category, or if they require an escalating dose of this medication over time, that's usually an indication that the medication is not so effective for that specific patient. And then they become a candidate for the other treatment strategies. And so the second line treatment, or the non-medical treatment, comes in two flavors. One is a non-ablative treatment. That's a functional treatment called microvascular decompression, which many of you may have heard about. I'll go over quickly. And that's a surgical treatment because it's thought to believe, for reasons that are somewhat ill-defined, but over time it's been felt that vascular compression, or a loop of a blood vessel pushing at the root of the trigeminal nerve where it exits the brain, is the primary cause of trigeminal neuralgia in type 1 patients for the great majority of people. And relieving that compression has a very durable and effective way to get patients pain-free off medication for the longest period of time. That is a surgical treatment, so there's some recovery involved, and I'll talk about that quickly. But the other kind of treatment is ablative, and that's a way to simply to numb the nerve, if you will, or knock it down in terms of its excitability. And we can do that by way of focused radiation, using a device called the Gamma knife, which is what I use, but there's other ways of delivering focused radiation, or needle-based procedures, or what we call percutaneous procedures, where we put needles into the face to the base of the skull where that ganglion sits, and effectively try to burn the nerve or chemically injure the nerve to calm down that nerve to help improve the pain. As I said, MRI scans are useful to look for tumors or multiple sclerosis or stroke. Some neurologists use an MRI scan to look for vascular compression, that thing that I talked about that's useful in MVD or microvascular decompression. But as it turns out, I have not found vascular compression on an MRI scan to be indicative of treatment success with microvascular decompression. I often see MRI scans that are completely normal, like in the great majority of patients. And at the time of surgery, if they fit the criteria for MVD, I find very large vascular loops pushing at the base of the nerve, despite the fact that it wasn't seen on a Fiesta sequence or a cis-weighted MRI scan of the brain. So while vascular compression, when seen like in this picture here with that pink arrow, is a good thing when you see it, not seeing it does not exclude somebody from having the surgery. And in fact, the great majority of patients with typical trigeminal neuralgia have vascular compression as the source of their pain, and decompression is quite effective. So microvascular decompression in this picture is an operation done with you asleep in the operating room. I make an incision behind the ear and make a window in the bone depicted by that dotted line. And that allows an access to get around the brain, so not through the brain, but around the brain as the brain relaxes away to get down to the brainstem where this trigeminal nerve exits. And what we see there, you can see on this left side of the diagram, is oftentimes a loop of the blood vessel pushing up against the trigeminal nerve. And the goal is to carefully dissect that away and pad that with the Teflon cotton or pledget that's placed between the nerve and the artery. And that, for many years, we have good data to show that that has a nearly 90% or more control rate in terms of getting patients off medication and pain-free for the longest period of time. This picture shows the blood vessel on the outside of the nerve just to show the nerve and blood vessel relationship. But one thing that I've seen in patients who've had quote unquote failed microvascular decompression when done by maybe someone who's not as experienced in it, the most common site of blood vessel compression is actually behind the nerve. So it's not right where you see it when you come in at the time of surgery, it's actually behind it. And for surgeons who don't do this often, that's a common source where that vessel is missed because they're looking on the outside, right where you see it, right where you come in, but actually it's behind the nerve. I do endoscopic procedures as well, depending on the patient's body style. And whether you use a microscope or an endoscope, all of the recovery and the tissue disruption is actually quite the same. The operation takes about 3 hours. It usually requires a 1 to 2 night hospital stay. And the only restriction I pose is no heavy lifting, meaning no more than like a heavy gallon of milk worth of weight for 6 weeks. That's the only restriction. Most patients are back driving at about 1 to 2 weeks after surgery once they get over the fatigue of a general anesthetic. As I said, the success rate is greater than 85, 90%. When you see a blood vessel loop, there is a small cohort of patients where there isn't a vascular loop compressing the nerve. And in those patients, I do a targeted procedure called a rhizotomy, or a direct cutting of some of the fibers of the posterior 1/3 of the nerve. And that's been fairly effective, particularly in some multiple sclerosis patients. Again, MVD is the most durable treatment to be pain-free off medication for the long term. Gamma knife radiosurgery is one of the ablative treatments where we try to knock down the excitability of the nerve. That's the way of giving focused radiation. The benefits of this versus MVD is it is a fully outpatient procedure, so there's no recovery process per se in the traditional sense of anesthesia. That procedure involves coming to the hospital on the morning of the procedure. I place a head frame, such as depicted in this picture, and the head frame is used as a coordinate for targeting the nerve with a very high degree of accuracy, and we can target it within a millimeter or less accuracy. And that procedure has a fairly good success rate, not as successful in the immediate term as MVD, not as durable, I'd say, in the long term as MVD, but still in the interest of something being outpatient without any of the risk of anesthesia. I think it still has a fairly good track record of all the ablative treatments in providing good pain relief in a non-surgical fashion. Percutaneous rhizotomy, in my personal practice, I reserve mainly in elderly patients or patients who have failed the other treatments that we just described, only because this generally involves placing a needle into the face using anatomic landmarks as depicted in that diagram on the left. And then we advance that needle using fluoroscopic guidance of the X-ray to the base of the skull where the trigeminal nerve root, where the trigeminal ganglion extends out into its fibers. And depending on the patient's distribution of the pain, we can either burn the nerve using radiofrequency or chemically ablate the nerve using glycerol. There's another procedure called balloon compression where it's similar in terms of how it's done, but a balloon is used to basically mechanically affect the nerve to reduce its excitability. This is a basic diagram of all the things we talked about. As you can see here, of all the procedures, the highest recurrence rate is with the percutaneous procedure. So they tend to almost always require a repeat intervention. So I tend to not use that in younger patients unless they've been refractory or have an atypical phenomenon that I felt they'd be a good candidate for it. Percutaneous procedures have a very good initial pain relief. But again, the recurrence rate is on the higher side. So oftentimes they require repeat intervention. Gamma knife does not have an immediate effect. Usually the treatment time requires about 2 months to get the initial treatment response. But usually the pain relief starts to happen as you get beyond that 2 to 3 month mark and can be durable for about 3 to 5 years. Most patients, however, can have a recurrence at that 5-year mark. Most of the time, we don't like to repeat radiation because there can be a compounding radiation effect. However, in select patients, we have done repeat gamma knife radiosurgery with good success and good durability when spaced out appropriately. Gamma knife, microvascular decompression, I said, is the gold standard treatment in appropriate patients. It has a very immediate effect and a very durable effect in the long term, and can be, of all the procedures, the most curative to get patients pain-free and off medication. Neurectomy is sort of the last line treatment in very, very severe and atypical cases. Actually, those in the 1 or 2 patients I've done over many hundreds is now done as an endoscopic endonasal procedure where we can go through the nose and endoscopically do a neurectomy. That I try to avoid as much as possible unless there's some good reason to do it after a multidisciplinary discussion with the neurologist and pain management doctors, because that can cause permanent numbness in one of the distributions of the face that has other consequences. But overall, this is a general overview of the treatment for primarily typical, but there's some unique scenarios where atypical facial pain patients can be directed to one of these treatment strategies depending on the situation with good result. And so that concludes sort of my formal part of this, and we can talk about anything you want to talk about in terms of questions, recovery, my thoughts about things, personal feelings about it in this facial pain condition.
I'd like to have, just to interject, John, if you can bring the people back up. I don't know if that's Pete or Doctor.
Yeah. Are you done sharing, Dr. Jacob?
Yes.
Yeah.
Great presentation.
Yeah, super.
Yeah.
John, I want John to speak to his recent MBD if you're still on, John.
Yes, I am.
If we get to there he is.
Hey, John.
Hello, Dr. Jacobs. Number one, hello, everyone. This is my first time on. I emailed Tim earlier this week to let him know that I had an extremely successful operation, MVD, just over 3 weeks ago. I was pain-free when I was in the recovery room, so it was awesome. And I just can't say enough good things about the doctor and the procedure that he did, and the relief I'm feeling.
I thought you'd be up on the table cheering the way you wrote to me, John.
Well, I'm a little more reserved than that, but yes, that would pretty much exemplify what I feel. Like I say, it's been awesome, and Doc, you're willing. You could talk about it if you want. I'm not worried about anything you had to say with the procedure. I know you mentioned something that it was a little bit different than normal because I had multiple crossings of the nerve and the vein.
Right. Yeah, no, I appreciate you for coming on, John. That's very kind of you. I recently operated on John, who had intractable facial pain consistent with typical trigeminal neuralgia. John actually had tried some of the medications and actually had a drug rash while he was away, and ultimately also had some of the side effects that have been quite significant. And as someone who's working in his level of employment and all of these things put together, John was a great candidate for this procedure. On John's MRI scan, actually, just like I had said, there wasn't like a striking feature of vascular compression on the imaging, but his clinical symptoms was highly suggestive of someone who would benefit from this. The interesting thing of his operation is he had a multiple branching of his superior cerebellar artery behind the nerve, which crossed in such a way that his nerve was being indented at multiple sites along the brainstem. So that required a little bit more in terms of operative time. But once I saw that and I came down on his nerve, I knew right away that this was going to be a really dramatic treatment response for him. And I was so excited to see that actual branching pattern, even though that sort of adds to the surgery in some respects. I knew when I saw that, that's a good indication of a good treatment response.
John, how long have you been suffering?
Oh, I'd say 4 years, right in there. As you know, it was on and off. And I actually had an appointment with the doctor last year around August, September. And then just really coincidentally, it started to go in remission. So we didn't pursue anything at that point. And then come Christmas, it came back. And again, it kind of started off slow, but it was back. And the episodes were longer and more painful, to the point that that's where I realized I couldn't do anything. We had another consultation. We tried the gabapentin never worked for me, and then we tried the trileptal, and then like the doctor said, I broke out in hives on that, and I just could not take that drug. And I'm not allergic to any drug that I know of prior to that. So that was a very unique thing for me. And again, kudos to doctor and Beaumont in general, because we diagnosed it on a Wednesday, and that following Monday I was in surgery.
Super. Somebody else, I think, started to ask a question. No? Can you pull the group back up, Pete? Is Peter there? He's in the basement. We have to ding him every now and then.
Yeah,
There he is.
I am so sorry. I blue screened out. I hope nobody missed anything. I was the only one out, right?
No, that's fine. Can you pull up the people? See if they have any questions.
Yeah, Dr. Jacob, can we stop sharing?
Yes.
That's a great chart, Doc.
There we go. So people can raise their hands, or they can send me a text, and we'll just get you in order.
You want to explain your symptoms again if you're not having too much pain?
Me?
Yeah.
Wendy. So, hi, Dr. Jacob. I'm trying to get a proper diagnosis if this is actually trigeminal neuralgia, or if this is sinus problems, or if this is headaches, or I don't know what it could be. I started with, I've been having chronic sinus infections for years. So they sent me to a ears, nose, and throat doctor. So I'm thinking I'm going to go into the ENT. He's going to find something structurally wrong with my nose. He's going to fix it. I'm not going to have any more sinus infections, and all's going to be good. I go in to see him, and he says, I think you have facial nerve pain. I don't think you've been having sinus infections at all. Because every time I have the facial pain, you go into a primary care or walk-in clinic, they press on you, you say, yes, I'm in pain, they write you an antibiotic, and they send you on your way. So he told me, I think you have facial nerve pain. Now understand, I've never heard of this before. Never. So I'm like, what? I didn't even know what to do. And then he sent me to neurology. I go see neurology. Neurology tells me you're having chronic migraine headaches. They never said if I did or didn't have trigeminal neuralgia, and they never said if I did or didn't have occipital neuralgia. So then I'm like, okay, well, the ENT doctor told me, when you think you're having a sinus infection, the next time, come in and see me. So I did. I thought I was having a sinus infection on March 11th. I went in to see him on March 16th. He did an endoscopy and no sign of infection. He said, I told you, you have trigeminal neuralgia. I said, so what do I do about it? He said, you're supposed to, didn't you follow up with neurology? And I said, yeah, I followed up with neurology and they haven't done anything. So I'm having all these mixed messages. So the ENT and the pain clinic tell me, yes, you have trigeminal and occipital neuralgia. Now I know I have occipital neuralgia because I've had nerve blocks. So I wouldn't allow them to stick needles in my head if I didn't need to. But neurology is still not acknowledging that I have trigeminal neuralgia. So I'm having a difficult time. How do I get properly diagnosed? How do I know what is causing?
Wendy, you just interject. You might explain the symptoms that you did for us earlier, exactly where they are on the head. And also she had multiple car accidents years ago. So just as background. But why don't you try to focus on the actual symptoms that you're having?
Okay.
Go ahead, Wendy.
Go, Wendy.
Oh, okay. Sorry.
Yeah,
Because I think really it comes down to, as I said, it's the history is really what says it. And I'll say that it's not uncommon that I see a lot of patients who are sent to me with this diagnosis of trigeminal neuralgia, and then I see them and they explain their symptoms, and that's not at all what they have.
No.
Now so we'll talk about your symptoms in a second, but in those situations, when it's not trigeminal neuralgia, trigeminal neuralgia treatment strategies obviously don't apply. But I think there's sometimes a scenario where patients have intractable pain phenomenon and neurologists or other providers get frustrated or not sure what to do next in terms of management, and then give it a diagnosis of trigeminal neuralgia, which is a very, very specific diagnosis. It's a very clear clinical history. And then send them to a neurosurgeon or other trigeminal neuralgia specialist, hoping that they can do something. But oftentimes, or I shouldn't say oftentimes, but some of the time it's not that at all. So tell me what you have in terms of your symptoms.
So my symptoms, I have pain across my forehead, around my eyes, my temples, underneath my eyes, my upper cheekbones, my cheeks, my lower cheekbones, and my jaw.
That's constant and on both sides?
Yes.
Always there?
Well, I have episodes. So like when I would think I was having a sinus infection, I have this pain. So it's episodic. And
but when it happens though, is it on and off, or you can have it for hours and hours and hours just there?
I can have it for weeks on end.
Weeks unrelentingly. And then it goes away.
Yes.
And it happens often on both sides together.
Yeah. Yes.
So that definitely is not trigeminal neuralgia.
Okay.
And so the question, of course, then becomes, well, then what is it? The trouble is, when it doesn't fall into a clear diagnostic category, and this is a hard thing both for providers to explain, because people want to help you, or help, someone who comes in with an ailment. But sometimes if it doesn't fit a certain diagnostic criteria, it's hard to give it a term. And one problem is the mistake sometimes I see is people give it a name because there's a name that kind of seems like it applies without a full understanding of what that diagnosis is. And once you're given that name, then all of a sudden that becomes the diagnosis. And then you see providers who treat that condition, but that's not ever what you had. But now it's in the record, and that's what your primary care doctor says. It becomes on the problem list as they're dictating. Problem number 1, hypertension. Number 2, trigeminal neuralgia. And that becomes part of your diagnosis until someone says, no, that's not what you got. And in your scenario, you obviously want to be helped of this problem. And it's frustrating because without a name, the primary doctor doesn't know where to send you in some ways. By giving it a name, they know who to send you for that condition, but that's not the condition you got.
Right.
It becomes kind of a problem. So I would say quite certainly that is not consistent with trigeminal neuralgia. Atypical facial pain or non-trigeminal neuralgia facial pain, that can be used for, I guess, in some ways, anything that gives people facial pain, but even atypical facial pain has some diagnostic criteria. I'd say from the symptoms you've described, it doesn't fit into that category clearly, given the bilateral nature and the constant nature of it, at least when the episode occurs. So I suppose your imaging was not particularly revealing in terms of sinus imaging or, nerve imaging. But I would say that's not trigeminal neuralgia from a clinical standpoint. And
you don't have any current imaging, do you, Wendy?
No.
Yeah, they didn't.
You haven't had any imaging done, you said?
Not since 2008.
And she stays in a dark room. I don't know if that means anything. The
dark
room helps you, Wendy, right?
Yeah.
The thing about migraine is migraine can manifest in very complex ways, meaning a lot of people can have migraine and actually have no head pain. Believe it or not, they can have migraine that's purely numbness of the face, or a change in the vision in one eye, or weakness in an arm. And that's actually a phenomenon called complex migraine phenomena. Almost any kind of symptom can manifest as, migraine headache in any which way. So I think, though, it'd probably be fruitful to get some kind of updated imaging just to assure that you're not having an evolution of some structural problem. I suppose you're not. But if not, then I think complex migraine phenomenon potentially makes more sense than any other diagnostic consideration.
Okay, so then I would follow up with neurology.
Right. And that's it's a trial and error kind of treatment and how they manage that. So it takes some time.
Okay. Well, at least that gives me a direction.
Right.
To go in.
Mm-hmm.
Okay.
But you don't want to be seeing multiple trigeminal neuralgia providers, because that's going to be a waste of your time too, by doing that and expense and heartache.
Right. Right. Well, thank you for your input.
Sure. Mm-hmm.
Thanks, Don. Anybody else have questions for Doctor?
I have a question.
Mm-hmm.
Tim and I have atypical trigeminal neuralgia, and it was through dental work.
Mm-hmm.
Why, doctor, would the percutaneous radio frequency thermal lesioning, that's a lot right there, why would something like that not work for atypical trigeminal neuralgia?
Well, with trigeminal neuralgia, that's typical, even though this vascular compression seems to be a common theme in terms of treatment and management. In the atypical category, it's even more ill-defined about what's the root cause of that pain cycle? What is the pain generator? The thing about facial pain that's different from the typical scenario, that pain generator can be anywhere along the pathway of pain, either from the brain or brainstem region, the thalamus, and then all the way down to the end organ or the trigeminal nerve, or even the very end organ, which is the organ like the teeth or muscle. And so when it's that situation, there's a concern that while percutaneous procedures can be done, sometimes the pain generator is actually way upstream of the nerve, and it's in the brain in a way that they can't see structurally. And what we don't want to do or have to be very cautious of is if you do an ablation to the nerve in the face using a percutaneous procedure, and actually the pain generator is coming upstream of that, that can result in a very difficult challenge in terms of how to manage that, meaning you have a numb face and pain on top of that.
Oh boy.
That's a very challenging problem.
And it's Della Rosa, probably, right?
Right, or at least the start.
Okay. One question, if you don't mind, just one thing. Have you heard of somebody putting in like a neuromodulator type situation in the, let's say, the neck area, where it could actually help your nerve pain for the atypical trigeminal neuralgia? And even if, say, you had peripheral neuropathy in, let's say, your hands or your in your body, let's say, have you ever heard of them doing that?
I have. I guess you'd have to clarify what exactly the nerve modulator is targeting. The modulator can be placed anywhere along the back of the head into the neck and even up above the clavicle. In terms of what it's targeting, I think will be the question.
Right.
Nerve modulation, despite where the generator is sitting, the nerve modulation, can be used certainly in intractable atypical pain. There's even motor cortex stimulators that target the pathways from the brain side that have been used in atypical facial pain.
Well, do you think this is the thing of the future where they're going to try to do, like people with facial pain or whatever, like, or atypical trigeminal neuralgia or peripheral neuropathy or whatever, where they try to use this type of procedure to block the signals, going to the brain, or change it or whatever it is.
I mean, for atypical facial pain or pain phenomenon, it's already being done, where they use neuromodulation, like motor cortex stimulation. That's already being done.
Oh,
I don't foresee that being a use case in typical trigeminal neuralgia. The treatment that exists is already so good.
Right. That's already set and done. Got it.
Without any untoward side effect that we don't yet know,
Right.
Versus a neuromodulation, we're learning more and more what can be other downstream effects.
Okay.
But an atypical phenomenon, it's already being done and even further made better.
So that's an option.
That is an option.
Maybe.
Yeah. I mean, there's some trial scenarios for that. Functional neurosurgery is the group that's involved in that. But it got to go through a lot of different trial periods to see if you'd be a candidate.
Right.
Someone would be a candidate for that.
Okay. Thank you.
Mm-hmm.
Thank you.
Aaron has the motor cortex, Mel. Aaron running. I think you met him online.
What, the spinal?
No, he has the motor cortex stimulator on the
in
brain.
the brain?
Electrodes on the brain, yeah. But he's had issues on and off. He didn't join today. He was having some issues with it. Mm-hmm. But to her point, Doc, just as an example, I know that it's the infraorbital branch off V2 that is infected from an infected root canal. Mm-hmm. What you're saying is you could go in and do a percutaneous or the peripheral stim, but you're saying the pain might really be up in the brain, and you might be doing this and causing more pain.
Right.
Because one of the things that the brain depends on, it's sort of like people who have ringing in the ear that you've probably heard of as a symptom for hearing loss. What the brain relies on is symmetry. So if there's an asymmetry, whether it's hearing or sensation of the face, it can compensate using an abnormal mechanism. In the case of hearing loss, the brain oftentimes compensates with the sensation of ringing or tinnitus or tinnitus. Sometimes we worry that if you numb the face, the compensatory mechanism to achieve symmetry by the brain might ultimately trigger a painful phenomenon that's hard to regulate because the brain is doing it. That becomes the concern.
That's what I was told by a neuro out in California back in 98, 99. He said, if the morphine's working, skip the procedures and
Right.
don't take any chances of causing, so I've stuck with it. But the pain blasts right through 400 milligrams of morphine a day when the barometric pressures change. And so I can feel what Wendy's been going through. At least it holds it down most of the time. Might lay me up for 24 hours, but I had hoped to get her to my pain specialist, and he just told me on Monday that he's got ALS diagnosed.
Oh, gosh.
Yeah, at University of Michigan, and we're looking for somebody to pick up his practice. Last time I checked with Beaumont, it's been years now, most of the pain clinics were run by the anesthesiologists, and they believe more in the needle than they do the meds. And in today's climate, it's even tougher because he's been harassed by the not only the feds, but the Michigan licensing people, because he's in the top 10 opiate prescribers in Michigan. That's all he does. I mean, he doesn't give scripts for anything else. So I throw that out there. If you got any ideas that you bump into a doc that's looking to pick up a large group of pain patients, he's ready to delegate. So again, I just learned Monday. We're thinking of some of us Mel-I and some others have, I don't know exactly his problems, whether we try to do a GoFundMe for him or whatever. I don't know his insurance backup and that, but he's got the slow moving ALS. But on either of those issues, if anything comes to mind, let me know.
Sure.
Sorry to get off agenda there a little.
Thank you, Tim.
Yeah. Tom, do you have anything? Questions for Doc? I can't remember.
I'm entirely medicated at this point, so we're doing pretty good.
You have the classic, Tom? I forget.
I have all the symptoms of the classic, and I'm on 600 milligrams of Tegretol. It's been a year, and everything is so far.
Great. So you followed his alternate number one. Yeah.
Right.
Yeah.
It's great. Well, you know where to go if it starts. They always say, Doc, over the years that the patient knows when it's time for surgery. And it sounds like John rang your bell and said, hey, Doc, it's probably time to get on the table, right, John? You knew.
Well, I didn't have any other options because I say medically I couldn't do anything. So yeah, that was the determination, and again, glad I did it.
Normally it's a progressive condition. I hate to say, Tom, but you might go the rest of your life without needing surgery. But it is a my experience of the 22 years of running the group, and Lynn would confirm that it is a progressive condition. But let's take in Lynn's case. She had the shocks and the constant. She had the MBD by your predecessor, Dr. Piper, God bless him, is passed. And it took care of a lot of her shocks, but didn't take care of much of her constant pain and other conditions. Anyway, you probably know the history preceding you, Doc.
Yes.
Dr. Piper. Yeah, just
yeah.
Anyway, we're happy to have you here joining us, but it's just tragic to lose him at such a young age.
Right.
Yeah. And we lost, before you arrived, Dr. Copeland up in Midland was doing the Gamma Knife, and he would delegate all his MVDs to either Doc Piper or Doc Malik at West Bloomfield and forward. Anybody else? Barbara, Susan, did you finish that ice cream cone out in California?
Yes, I did. Luckily, I can still eat ice cream.
Yeah.
I'm one of the unlucky ones that had the rhizotomy that left me much worse off than I was.
Did you have Birchall do it?
No, I had Dr. Chen out here at Stanford.
Oh, okay. Didn't work at all?
No, it made me worse. My eye now hurts and my cheek and the whole side of my face. Whereas before it was just the gums, and the roof of my mouth. Mine started after I went to get my teeth cleaned, and the dentist said, "Oh, you've got some receding gum line. I can fix that for you." And I've had pain ever since.
Have you tried opiates at all?
They've been given to me, but I'm scared to death to take them.
We need to talk more on the side.
Yeah. I also had CyberKnife at Stanford, and I had about 5 or 6 nerve blocks at UCSF, and neither I've had the special MRI, the thin scaled or whatever it's called MRI, and Dr. Chang at UCSF, he's the neurosurgeon that does MVDs at UCSF. He won't touch me. And Dr. Chang at Stanford, he's the neurosurgeon at Stanford, he won't operate on me. Dr. Linsky out down in Southern California said he would, and he would give me a 50% chance of a 50% reduction in pain.
By doing what?
MVD.
Not with the gum. How does that relate to having a gum dental problem?
Yeah, I mean, I'm convinced that my nerve was injured by the periodontist.
Who did the cyber on you?
Dr. Chang at Stanford.
Just for everybody out there, our position is, Lynn and I, stay away from the CyberKnife. You got to use Gamma Knife. CyberKnife is causing. Normally, we have a young lady from Kalamazoo on here that had the cyber at University of Chicago, and she's all, I don't want to use the language that I feel, but she's in such bad shape. Her eye and everything else, same thing. Anybody that's listening, and we'll talk later, Doc, about how we normally do it on YouTube, if it's okay with you. Anybody listening out there, stay the hell away from the CyberKnife for trigeminal neuralgia. Might be good for tumors and other things, but don't let anybody touch you with the CyberKnife. Got to be Gamma Knife. If you decide on radiosurgery, I don't think I can be any more firm than that, other than coming through the screen here. And I apologize for being overly vocal, but I've seen.
Well, I had it. I had the CyberKnife, and that did not increase or decrease my pain.
Well, you're lucky.
Yeah.
You're lucky. Yeah, because the other lady, she's in such a bad shape.
I think I seen her, Tim.
Yeah.
On one of our meetings, and she was in horrible shape. Horrible.
Probably why she didn't join us tonight, because of pain. Yeah. The weather's been fluctuating. Barb, do you have anything from Toledo to add? Maybe she's not mic'd up.
I just asked her on mute.
Yeah. She might not. She's representing a fella that lives a couple miles from me here in Troy, but I don't know his status. Anyway, Tom jumped off. I think that's about it, rather than holding Doc up, if nobody has anything else. 2 things, Doctor. rather than me emailing you. If I can get a copy of that one chart, if it's easy to do, the one that had the procedures and the percentages. I don't
Sure.
know if that's easy to duplicate. If somebody can do that, otherwise forget it. And the other thing, are you okay with us we have 29 videos on YouTube. I think you and Dr. Grills, I don't know if I got around to that. I'm about 6 behind. My son-in-law helps me with that when he's got the time. Are you okay? Pete cleans this up. Are you okay with us putting this on YouTube?
Sure.
Thank you.
Thank you.
And Pete, leave that cyber knife, even though I was a little vocal. Please leave that in when you slim it down.
You want a disclaimer, Tim?
Thanks, Dr. Jacob. That's been
Absolutely.
an excellent presentation.
Thank you.
Yes, thank you.
All right.
Thanks,
Thank you.
Thank you.
being on. Thank you.
Thanks, John, for coming on.
Good luck,
All right.
John.
Thank
Good-
you.
Good job.
All right.
Glad to
Take
hear
care.
you.
Good care.
Thanks, Peter. Wendy?
Yeah.
We'll keep working, girl. Okay, we'll talk.
Okay.
Yeah,
Thank you.
yeah.
Tim, did you want to talk about those pointers about the other meetings and things? Did you want
No, they're pretty self-explanatory.
to? Okay.
I hate to keep the doctor any longer. If they
Oh, of
just,
course.
Yeah.
I guess the one, because it's going on YouTube as soon as I can, are those symposiums. I guess I could have brought those up, especially that Cleveland Clinic symposium on TN. Shannon out at Stanford, I think he was on the webinar that I was on, but afterwards Susan said, I better be quiet.
I can hear you talking about me.
Yeah, I know. Cut that part out. Yeah.
You want me to stop the recording part here, Tim? Just while I have all the time in the world, but you want me to stop the
Yeah,
recording?
yeah, I think we can stop the recording.
Stopping recording.
Yeah, Susan, do you have anything to add?